Surgery Division. Thank you all for joining us this morning for Grand Rounds. Special guest this morning, Dr. Milosano from Italy, coming to speak to us about the history of aortic surgery, near and dear to the Houston surgical heart, for sure. Huge history here, and Dr. Milosano, during his training and early career, actually came and spent some time in the days when Dr. Caselli and Safi were still here at Methodist Hospital. He's an extremely well-published and well-written author in the vascular surgery literature. Gave us a great talk last night about aortic dissections and current management strategies and the challenges and equipoise that's prompted many of the ongoing trials, including the Improve AD trial that's here active at Houston Methodist. And Dr. Milosano, thank you so much for joining. We look forward to your talk this morning. As he comes up, just a few housekeeping notes. Recall, if you're going to ask questions, please use the speaker. If you're online, recall that this is being recorded and will be available later for viewing. If you're wanting to ask questions from online, you can text questions to DeBakey at 37607. Upcoming training activities, Re-Evolution is coming up in March next month, the Fellows Training for ACHD in April, and CVD prevention in April as well. Thank you very much.
Thank you so much for your kind introduction. I must say that it is an incredible honor for me to be giving these grand rounds here at Methodist, and I am hugely grateful to Dr. Lumsden for the invitation. It's really wonderful to be here again with this very distinguished role. So, Alan, thank you very much. And I thought that there was nothing that I could possibly teach about aortic surgery here in Houston, so I thought I would just try to entertain you with some historical facts and trivia. So we know that surgery was performed in Egypt 5,000 years ago, and in Mesopotamia also. This is a very beautiful artist depiction of a lion that becomes paraplegic after he's been hit by an arrow, and it reminds us of the worst thing that can happen to our aortic patients. And probably there was a description of an aneurysm in Greece from Antyllus. In Rome they had a lot of trauma to deal with. But here we come to the 3rd century, Anno Domini 300, and this is a medieval picture of the saints Cosmas and Damian, and they were called anargyroi, which means without silver. So basically it means they did not charge their patients, so exactly like we are doing now here. And also there's other things that never changes that you see here. This is, as you can see, the procedure is a lower limb transplantation. So this is the patient's limb and this is a donor's limb. And one thing that also never changes is that the nurses are angels. So the first time that usually that there was a contact with blood vessels was in the Middle Ages, most all over Europe, but mostly in England, and it was bloodletting. So bloodletting was performed for all different kind of diseases, and the subject or the patient would be grasping a rod, and then a phlebotomy was made in his arm, and the blood was let drip into a brass container. And this procedure was made by barbers. Okay, so for the barbers to let people know that they offered these services as well as cutting hair, they would put the brass container full of blood in front of the shop. And eventually, especially in summer, this would rot and would become really putrid and stinky. And so at some point, the government of London, in the year 1307, decided to prohibit, putting the blood there. So the barbers needed for people to know that they were actually still doing the bloodletting. So they introduced this sign, the barber's pole, which show you the rod and show you the brass container here, and also show you this white and red stripes depicting the blood. The bandage that were dirty with blood and that were put there. So actually the barbers kept doing most of the surgery in England for many centuries. At some point they founded this company of barber and surgeons that eventually became the Royal College of Surgeons as opposed to the medical doctors. And this is the reasons why even nowadays, once an English doctor becomes a fellow of the Royal College of Surgeons, he gives up his title of doctor and becomes again Mr. or Mrs. So in the meantime, in Italy, we had this very important person, incredible artist and genius Leonardo da Vinci, who made these wonderful depictions of the human anatomy. However, he had, like anybody else at his times, he had absolutely no idea of how the circulation system worked. And we had to wait for another century for this to be discovered by William Harvey, again in England. And he was a doctor, but also he was a farmer. He had a farm with many animals, and he would do a lot of experiments, especially putting glass tubes inside the heart or the great vessels of the living animals and seeing how the pressure would work, and also in smaller animals looking at the end of the animal's life when the heart rate was slowing down, how things worked. And also very smart things that you can do also in a human to figure out in which way the blood is flowing in a vein. So you can do that on yourself or on your colleague and see and prove that in a vein the blood flows toward the heart. So he got it all worked out, but there was a missing piece that he could not figure out how the blood could go from the arteries to the veins, because of course he could not see the capillaries. So he postulated the existence of the capillaries, and then eventually when the microscope was devised and then perfected by another Italian scientist, Galileo Galilei, it was possible to actually see the capillaries. So in those times, not much was done to vessels except probably trying to close ligate them, as did Ambroise Paré with this tool here that he devised for amputees during the wars. So we go back to England, 1760, and we read in the annals of the British Crown that on the morning of 25th of October 1760, King George II, and by the way, the state of Georgia is named after him, rose at 6 a.m., drank a cup of hot chocolate, and went to his closed stool. After a few minutes, his valet heard a loud crash. He entered the room to find the king dead on the floor. Now, at those times, quite interestingly, all the sovereigns, once they were dead, they received an autopsy, just to make sure that nothing funny happened to them. And the results of the autopsy were published on the newspaper, on the next day newspaper. So we can read in this gazette, upon opening the body of His late Majesty, the pericardium was filled with a great quantity of extravasated and coagulated blood. The coats of all vessels were worn away extremely thin. So this is possibly the first accurate description of a type A aortic dissection. And then still in the 18th century, we had John Hunter that described aneurysms and also provided this incredibly interesting specimen of a popliteal artery aneurysm that you can still admire today in the Hunterian Museum in London. And I really encourage you to visit this very interesting museum if you go to London. And as we will see, the history of vascular surgery is very much connected to wars. And so we begin with Napoleonic Wars. We know that Waterloo was in 1815, and at those times the only things that were done was cauterizations of the wounds, which often caused more damage than benefit. Amputations and infections were really commonplace there. And this chap, Charles Bell, was a doctor and an incredible artist who depicted very vividly the wounded people in the Napoleonic War, and also the complications such as tetanus in this case. And these wonderful paintings can be admired in the Edinburgh Museum of Medical Science. And you can also read about it in this paper that you can find in the literature. And during Waterloo War, about 80,000 young and otherwise healthy young men died. And the corpses were scavenged for about everything, including their teeth. And for the next decades, so-called Waterloo teeth were the best false teeth that money could buy. And they were made by actual very healthy teeth from young men. And this chap here, Robert Knox, brings us again to the origins of our gracious here host and your chairman, Dr. Lundsman, because he also was in Edinburgh, and at those time anatomy was being taught like privately, so you can see here the price of the lessons was, I think, £3 and 5 shillings for the first course and only £2 and 4 shillings for the second course. And different teachers would try to get as many pupils as possible by offering as many autopsy cases as possible. So they need to procure the corpse, and there was actually a market for that. And body snatching by this so-called resurrection man was a very popular job at those times, and then the corpses could be sold to the anatomists. And in order to avoid this, many people would buy a mort safe to make sure that the body was not stolen by these resurrection men. So quite interesting, these two chaps here, Burke and Hare, were selling corpses. And they made a very fair living with it, but at some point they got greedy and they started killing people instead of getting the corpses, and so including their landlady to whom they owed the rent money. And at that point they got caught and they got executed. And the skeleton of Mr. Burke is still now for show at the Edinburgh Museum. So another thing that you can. And to avoid this, at some point in 1832, the Crown published this Anatomy Act, which at that point allowed for unclaimed body to be used for scientific purposes. And so at that time, this market stopped. And now we are back in Italy with Antonio Scarpa. In 1805, he was a master of pathology and anatomy. He made these fantastic specimens under alcohol. Here you can see probably the first wonderful drawing of a thoracoabdominal aortic aneurysm. And he was really keen about preserving the specimen in alcohol. So at some point when he passed, his younger colleague put his head under alcohol, and you can still admire it in the Museum of Pavia, the head of Scarpa. And then Astley Cooper performed this ligation of the aorta, and another guy from Edinburgh, James Simpson, showed that chloroform could be used for anesthesia, so this was much easier to administer than ether, and allowed more surgical operations to be performed. And then Rudolf Madas was the first to ligate the aorta in case of an aneurysm, with unfavorable results, I must say. And in those first decades of the last century, an array of different solutions was tried for aneurysm, including wiring them and putting current in them, doing an endoneurysmorraphy, or wrapping of the aorta with either fascia or some other material. And while this operation and the surgeons who did it may not be very popular, one of the patients who received it is extremely well known, and it was Albert Einstein, that had this ongoing abdominal pain that he could not get rid of. So at some point his surgeon did an exploratory laparotomy and found a big aneurysm, and he did wrapping with cellophane. And I mean, the the pain went away, and he lived for several years. And then after sometimes when the actual operation was devised here by Dr. DeBakey, he offered him a proper aortic replacement. But at that time, Einstein refused, and he said, I want to go when I want. It is tasteless to prolong life artificially. I have done my share. It is time to go. I will do it elegantly. And so he never received the proper operation. So here's another interesting device that was used to compress a ruptured aneurysm. One would wonder what happens when it was dinner time and you have to let the compression go, but it is what it is. So, of course, radiology is extremely important nowadays. We use it every day, but it was discovered in 1895 by Wilhelm Röntgen, and this is the first medical radiological picture. It is the hand of his wife. And you know, when you have something new, you think that you can do a lot of things with it. And one of the things X-rays were used for at the beginning of the century was to remove superfluous hair. And it was done permanently, painlessly, and no chemicals, no needles, no wax. And it worked like a charm. So the hair went away beautifully. The problem is that it did have, of course, also catastrophic consequences. So we must be very careful when something new is brought into the medical practice to stay away from the unproven use of it. And now you get to meet Alexis Carrel, who is one of the few surgeons who received the Nobel Prize in 1912. And his contribution to vascular surgery were really countless. And here are just a few of his main contributions. He devised vascular sutures, vascular technique to suture the vessels, replacement for blood vessels, organ preservation, organ transplantation, wound antisepsis, and studies also on cellular senescence. And here you see in this Time magazine of 1938, he's depicted with Charles Lindbergh. And I am sure you have heard of Charles Lindbergh. He was an engineer, and he was the first person to cross the Atlantic Ocean solo on a plane. And also, he became quite famous for a very sad reason. His 2-year-old son was kidnapped and then murdered, and this also made a very popular Hollywood movie a few years ago. Anyway, Lindbergh devised this perfusion pump for the preservation of organs to be transplanted, and it became the basis for the heart-lung machine that was first introduced by John Gibbon in Philadelphia in 1953. As you can see, it's very bulky. It was a complicated machine. It took several years to perfection and to become a common place in all the surgical services over the country. However, in the meantime, many kids were still dying of ventricular septal defects, atrioventricular septal defects. So this guy here, Walton Lillahei, thought of using the parent of the child as a heart-lung machine for the kid. And this is so-called cross-circulation. And he performed a number of very successful cases with this technique. However, at some point, mostly due to political reasons in his hospital, the management stopped him, saying that this was the only operation in the world that could have a 200% mortality. So it was unethical to do it, and this is only one of the many interesting things that happened to Walton Lillahei. And quite interestingly also, it occurred that after some of these operations, the kid did okay hemodynamically, but developed a heart block, which was really a big problem at those times. So in his hospital in Minneapolis, there was a chap called Earl Bakken who basically did he was an engineer. He basically had a workshop in the basement of the hospital and took care of all the electrical equipment. And so he talked to Erbach and he said, we just need to stimulate in some way the heart of these kids. So he figured out a way to do that. with a wire in the epicardium, and then this little machine that you can see here that would produce stimuli, and this was the first pacemaker. And Erbakan went on developing more advanced pacemakers, and he also founded a company that became quite successful in Minneapolis, Minnesota, that's Medtronic. So if you are interested in the incredible life of Walton Lillehei, there is a very interesting novel-like book called King of Hearts. And if you think that this is all BS, it is not. He's an actual person, and I had a very big honor of meeting him when I was very young, and he was quite old, but still in meetings. So we go back to Europe now, still in the first part of the last century, and René Leriche in Paris was the first one to realize, to put together the occlusion of the aorta with ischemic symptoms in the leg. And he did not think that it was possible to operate on the aorta directly at those times, but he figured out that sympathectomy would cause a good vasodilatation and could help this patient. So what is really interesting is that at those times, in spite of the difficulties of traveling overseas, etc., you can see that in his service there were a number of very prominent guests, including Michael DeBakey, including Jean Kunlen, including Sid Dos Santos, and others. So you see, it's really important for good ideas to spread, that we travel, that we meet our colleagues here, that you go to other places, and it's very, very important. So now we arrive at World War I, and here people start understanding that the germs are at the basis of infections and try to avoid that. And then the first military hospitals were founded. So here you have John Lister that produced this antiseptic solution that was actually sprayed on the surgical field, as you can see here. And also, if you use Listerine mouthwash, now you know where the name came from. And I owe an apology to our Hungarian colleagues that are here today for not mentioning Dr. Semmelweis, who was actually the first really to understand the importance of antisepsis before the others. And you can read his story in a very nice novel from Céline. So once again, Carrel, together with Dakin, also devised this very effective antiseptic solution, which is the Dakin-Carrel solution, which is basically sodium hypochlorite. And during the COVID, we all realized how important it was, to scrub our hands with a little bit of this solution that became like $4 for a small ampoule at some point, but. And here we have the first military hospitals, and here there's another interesting story. So you know that aspirin here is sold in drugstores, and anyone can produce and sell aspirin. But in the rest of the world, this is not the case. Only Bayer can sell aspirin. The rest must sell acetyl salicylic acid. So why is that? Now, the reason is that during World War I, aspirin was an extremely important strategic product, because if you had aspirins and your troops had a fever, you could load the fever and let them fight. If you did not have aspirin, they would be just very sick with their high fever. So during the Treaty of Versailles, where the peace treaty was signed, Germany that lost, or Prussia, better say Prussia, that lost the war, had to give up the patent of aspirin in the United States of America. So Bayer no longer holds the patent for aspirin in this country due to this treaty. And now we get to meet another interesting chap, Egas Moniz from Portugal, from Lisbon. He is the next surgeon that we meet that won a Nobel Prize in 1941. And he was a neurosurgeon, and he was the first that showed that Cerebral angiography was possible by means of direct puncture of the common carotid artery at the neck. So you would say, well, that's a very important achievement, so he deserved the Nobel Prize, but actually this is not the case. He got the Nobel Prize for another operation that he devised, which is lobotomy. And lobotomy was offered to schizophrenic patients to calm them down, and in his original operation, you had to do a craniotomy here and then slice the brain open with this scalpel here. But of course, not many crazy patients were crazy enough to undergo this. So once again, the Italian genius, Amuro Fiamberti, realized that the operation, lobotomy, could be performed in an ambulatory situation by just sliding a small needle through the orbita on the side of the eye, of course, and in 5 minutes he could do the lobotomy. So this operation in those times became incredibly popular. And actually, this American guy, Walter Freeman, did over 200,000 lobotomies, and he would tour the whole country with his lobotomobile, and he had a long line of patients outside his truck, and took like a few minutes to do the operation. Then, of course, it was not always really successful, but it was really popular at those times. And here we have another Portuguese guy, Reinaldo dos Santos, who was the first to do aortic angiography. And then we have Murray that showed how heparin was used as an anticoagulant, initially in hemodialysis, and then, of course, we know that this is what makes most of our operation possible, the administration of heparin. And now we arrive at World War II. World War II was the first instance where antibiotics like penicillin were used, and it saved a huge number of lives. And also, it is the first time here we meet Dr. Michael DeBakey serving in the US Army as Army doctor. And here we have Juan Carlos dos Santos, who was the son of Reinaldo, who was the first to perform an aortic endarterectomy in Lisbon in 1946. And in the same year, Crawford and Gross showed that homografts preserved from cadavers could be used to replace the aorta, and they did the first operations in an aortic coarctation. And with homograft, DeBakey was the first to replace the thoracoabdominal aorta in 1955. And these are also the years of the Korean War. So at this time, field hospitals were introduced. And for those of us who are old enough, you all remember the MASH TV show that showed these heroic doctors working under duress and very hard conditions. In the meantime, in Europe, Jacques Oudot, who was working in Paris, was a very passionate mountain climber. Here you can see him climbing the Annapurna and saving the limbs of some of his fellow climbers by injecting vasodilators in the artery. And he did a lot of research on replacing the aorta. Unfortunately, at some point, he died in a car accident. But following up on his research, and the next year, Charles Lubost in France was the first to replace the abdominal aorta with a homograft. And in those years, ladies' stockings were extremely expensive. It was basically something for royalty or really rich people because they were made of silk. And then in 1930, DuPont patented this new fiber, synthetic fiber, that you can see here with different names, but it's the same thing. And it became hugely popular, and so now everybody could buy stockings for a few dollars. And they did that until 1941, when they had to stop using this fiber for the stockings because all the fiber was used for the parachutes that were used during World War II. Now, Japan had the silk, they had the silk parachutes, but in America the supply of silk was very limited. So all these new fibers was used for the parachutes during the world effort, and it became known with another acronym, which is nylon. And here you can see where they took this acronym from. And of course, different synthetic fibers were then available. And Vignon N was the first synthetic fiber that was used to replace the aorta by Blackmore and Voorhees. Here you can see Dr. DeBakey using a woven fabric and building his own bifurcated graft using his wife's sewing machine. And also knitted graft were devised by Sheen and Campbell. They were easier to handle, but they were more prone to dilatation. So woven was mostly used for the thoracic aorta and knitted for the abdominal aorta. You can see the differences here. But the problem with those fabrics was the porosity of this fabric was actually larger than the red blood cells. So these grafts bled like crazy. And so they needed to be pre-clotted, and the most common way to do it was to soak them in plasma or albumin and then bake them. And I remember perfectly the grafts being baked in these very hospitals in the 80s with albumin. And albumin is a protein that, of course, is also the base of the white part of the egg. So if you think of what happens to the white of the egg when you bake it, it becomes solid. So it seals very nicely these grafts. And now, of course, they are pre-clotted commercially, but still with gelatin and albumin. And with these synthetic grafts available, Dr. DeBakey and also Dr. Cooley, which we get to meet now, basically were able to replace all the segments of the aorta, all the possible vessels you can imagine were replaced by DeBakey and Cooley in the 60s, and or including dissections, of course. And then at some point, Dr. Cooley thought that it was also possible to replace the function of the heart with a mechanical device. And he did this in the first patient here, and I believe that this device is still in St. Luke, where you can see it. And the artificial heart over the decades became the reason for a very bitter feud between DeBakey and Cooley, but they lived long enough to make peace at a certain point, and there was a reconciliation when both of them were over 90. And quite interestingly, Dr. DeBakey, at some point when he turned 97, he got his own aortic dissection, and he initially didn't want to get the surgery, but then the wife convinced him, and Dr. Noon, that you can see here, performed the operation, and then he lived for several years after that. So back in 1997, Ettridge was the first to replace the thoracoabdominal aorta, but probably the most important champion of thoracoabdominal aneurysm is Dr. Stanley Crawford, and he published a series over 600 cases back in 1985. And in this picture here, you can see many of the giants of cardiovascular surgery here in Houston, including Dr. Cooley, Dr. DeBakey, and Dr. Crawford. And you know already that Cooley and DeBakey lived up to 100 years. Unfortunately, Dr. Crawford did not. He passed in his 60s, and you can see the reason why here. And of course, there is a legacy from these giants, from the DeBakeys, the Cooleys, the Crawfords, and Dr. Coselli picked up his legacy after Dr. Crawford passed, and as it was mentioned in my introduction, I was here when I was really young, and also Dr. Coselli was quite young. So we move now to another chapter, the chapter of endovascular things. And so the first cardiac catheterization was made by Dr. Judkins, and quite interestingly, he inserted this plastic tube from the cubital vein in his office, and when it was all the way in, he walked down 2 stories of stairs to go to the radiology department, got his chest x-rays, and this is a chest x-rays, and he proved that the cardiac could be catheterized from a peripheral vein. Here you see another giant of cardiac surgery, Dr. Christian Barnard in Cape Town, and you can see Dr. DeBakey discussing heart transplantation with him. And we come to the Vietnam War, and here things changed a bit. Air evacuation began with helicopters, and revascularization of the limbs was started with bypasses. And really, vascular surgery owes a lot to the Vietnam War, and namely to Norman Rich, who put together a registry with over 10,000 patients that they were followed for decades after that. And I think it's always very interesting during this meeting to hear at Dr. Rich's lectures on this war. And we are now in 1977, and in Germany, Dr. Grunzig shows that the coronary artery can be opened up with a balloon. His initial balloon was compliant, but then it was shown that non-compliant balloon did a better job. But unfortunately, as you know, after angioplasty, many of this artery recoil. So something was needed to keep them open. And it was Julio Palmas who devised the first balloon expandable stents. And of course, this completely changed the game of endovascular procedure, and he made a fair amount of money out of this idea, which allowed him to go back to Argentina and make the most beautiful wines there. And of course, you all know about Juan Carlos Parodi, another Argentinian guy who had a smart idea of blending these palmat stents with vascular grafts and performed the first EVARs. Quite interestingly, the first paper was rejected by the Journal of Vascular Surgery. So if you get rejections for your papers, don't be depressed. There's always second chances. And so it was published in a minor journal with the first 6 cases, and you all know how that ended up. And then a few years later, endovascular repair was also performed in the thoracic aorta here by Mike Dake. But actually, before Dr. Dake did that, Nikolai Volodos performed this TEVAR in Ukraine. But at that time, Ukraine was a Soviet Union, so it was published in Cyrillic in a local journal, and it was discovered only in 2001 that he was actually the first to do a TEVAR. And of course, we think of endovascular. There is one hero here. My hero for endovascular is Roy Greenberg. He was a very dear friend, and unfortunately passed away too early. And as this lecture comes to the end, I'm just going to very briefly mention heritable aortic disease. And there are heroes of the past for genetic aortic disease, such as Marfan, Ehlers, Danlos, and none of them were aortic guys or even surgeons. But nowadays we have our own heroes for heritable aortic disease. I'm just mentioning a few here. You have your very own Diana. We have John Eleftheriades from Yale, and then we have Bart Lois and Hal Dietz. Now, Hal Dietz is a cardiologist, not even a genetist at Johns Hopkins, and Bart Lois from Antwerp, and he's a genetist, and he was doing his PhD at Johns Hopkins, and he realized that some of the patients that went to the Marfan clinic to see Dr. Dietz had some slightly different characteristics, and he was able to connect a different genetic situation to these patients. And now we know that this is a different disease that we know as Lois-Dietz syndrome, and here are the same Lois-Dietz a few years later enjoying a nice glass of wine with me in Antwerp. So this being said, once again, it was a great pleasure and a great honor to give this lecture this morning. I hope it was at least a bit entertaining, if not interesting, and I would like to take this occasion to once again thank you, my gracious host, for his incredible hospitality, and to invite everybody in Milan in December for our aortic meeting. Thank you very much.
Great, thank you so much. If we can pass the speaker around or microphone around for questions. Can you tell us about your meeting? What does it consist of? It's hands-on, it's purely lectures?
Okay, so we have been running this meeting now for 20 years, and we do it every other year, so that there can be always something new. So we have main room lectures, we have workshops, we have hand-on, everything there. And the good thing is that everybody who is in training is very welcome at the meeting, free of charge. So anybody is more than welcome, as long as there is the blessing of Dr. Lundsen.
Dr. Lowry, you had a question?
Well, thank you very much. Thank you very much. That was a great lecture. I really enjoyed it. I came here in 1974, and it was a very exciting time, to say the least. I did have a couple of comments, the most important of which is that you failed to mention the Royal College of Surgeons of Edinburgh, and Dr. Lumsden, of course, and I are both fellows of that college, which is notable for the fact that it was founded in 1505 by James IV of Scotland, and is the oldest college of surgeons in the world. So now I lived in London.
I try to add to the lecture as I learn myself. It's ongoing process.
Excellent. Now I had the privilege of going to the Royal College of Surgeons of England's basic science course for 5 months in London, next door to the Hunterian Museum, and as you say, it's very much worth the visit. Just for other members of the audience, the significance of the Hunterian popliteal dissection is the fact that this was translated into a surgical procedure, which I think is generally credited with the first surgical cure of aneurysm by means of a ligature placed between the lower collaterals from the superficial femoral and the aneurysm, inducing thrombosis with continued perfusion in some patients. Obviously, limb loss rate was fairly high. I had the privilege of meeting Charles DeBakey. I'm not that old, but he was pretty old, and we had a surgical program in Saudi Arabia that Dr. DeBakey had set up. And Dr. DeBakey was had developed a great interest in Egyptian archaeology in his later years. And as you probably know, this program in Saudi Arabia and Riyadh had actually been staffed by French surgeons for a number of years. And so he visited us there, and I had the privilege of meeting him, so that was quite a pleasure. Now, there's a book that I think is worth everyone who's interested in this history should read, which is called A Time for All Things. It's essentially the official biography of Dr. DeBakey. It's a very comprehensive and very thorough book. And it does spend quite a bit of time on this issue of the artificial heart and who was responsible for it. And I think the consensus is that there's no question Dr. DeBakey developed the artificial heart, and then it ended up being transplanted under some different circumstances at St. Luke's. But if you want to read the details, by all means go to that. Dr. Crawford, his death was pretty shocking to all of us. He died at 69 of a stroke and lung cancer. And just to emphasize the clinical acumen of the surgeons here, we had a little surgeon's room off the operating room, and it was essentially almost impossible to see in there. The cigarette smoke was so dense. There were some cigarettes from Louisiana called picayunes, which were, well, you probably remember the smell of it, actually. But Dr. Crawford actually had his stroke and was unconscious in this room while surgeons went in and out for about 2 hours before one of the orderlies finally noticed that the cigarette had burnt down in between his knuckles and raised the alarm. So I guess sometimes surgeons aren't that strong clinically. But that was a great lecture. I enjoyed it a lot. I'm sure you remember the days and how exciting it was and the challenges involved with these grafts that bled like crazy when you took the clamps off, and how ill these patients were. The anesthesia was really pretty terrible by modern standards. And Dr. DeBakey's famous line was always, everything was fine when I left the room. You know, as he left the room, went upstairs, something terrible happened, you had to call him back.
I thank you very much for your comments. I would be hugely grateful if you could share some of your sources with me for the next version of this. And actually, talking of Dr. DeBakey, I found a very interesting collection of his comments to the residents, and I think he would be in jail if he did that now.
Definitely.
But you really don't want to know what he said to his residents.
Well, there were a few physical assaults on residents. One resident had his thumb broken, actually, in that time frame. And Dr. DeBakey was actually unconscious at the time he was taken to the operating room. His wife was the one that pushed the surgery, and he had actually left written instructions not to be operated on.
Right.
But it all worked out well for him, thank goodness.
Exactly. It's always the women that rule.
Perhaps out of place and perhaps out of context, but for those who have not listened to it, the podcast Cardiac Cowboys that talks about Lillehei, Bernard, Houston Giants, etc., for the non-cardiac surgeon is a really fantastic and capturing listen if you've got time in the car and your commute.
And that's actually based on a book, Cardiac Cowboys, that you can get on Amazon. And it's actually well worth reading, definitely.
It's really well done for sure. I've not read the book, but the podcast is really fantastic.
So I first heard Hermano give a version. As he said, this is a live thing that continues to evolve in Edinburgh. When he talked about a lot of the Edinburgh history, so I went to medical school in Edinburgh, and he's right. That skeleton, he was condemned to die from stealing these bodies, and his skeleton was going to be hung in the medical school museum forever. And so you all go by there as a medical student. And Knox was the surgeon and anatomist who was buying the bodies. And so it says something about the Scottish psyche. And that, now I'm going to read this to you. There was a nursery rhyme created around that. The nursery rhyme, I remember. And it said, up the close, which is a little space, and down the stairs, button Ben with Burke and Hare. Burke's the butcher, Hare's the thief, Knox the boy that buys the beef. And that was developed for children in Scotland. So it's fascinating. You weaving all this stuff together.
All right, great. Thank you so much for attending the conference today, and we'll look forward to the next one. Thank you, sir.
Thank you.